Alright, this is chapter 28, and we're going to be talking about soft tissue injuries. Alright, in this chapter we'll be recognizing and discussing the management of wounds. Burns to include electrical, chemical, thermal burns, also chemicals in the eye and on the skin. Cover some pathophysiology, assessment and management of wounds, such as avulsions, bite wounds, lacerations, puncture wounds, and incisions. Also burns as far as electrical, chemical, thermal radiation, and the crush syndrome. So in a lot of your patient care, especially in trauma related, you're going to have a multiple injuries, and soft tissue injuries are going to be one of your more reoccurring ones and the ones that you will see a lot. So, becoming proficient in how to care for these injuries is going to be pretty vital, because there is a lot as far as different diseases and stuff, and bacteria that can enter the skin through soft tissue injuries, because the skin is the first line of defense for the body. It is susceptible to various injuries, and the soft tissue injury may result in exposure to deep structures such as your bones, to the point of that. So dressing and bandages are applied to control bleeding, prevent further contamination, also to provide or protect the wound from further damage itself. Injuries can be, such mechanisms of injuries can be blunt injuries, penetrating injuries, and burns. Death from soft tissue injuries also often related to hemorrhage or infection itself. So, protective actions are necessary to prevent injury, the use of gloves, workplace safety measures, and teaching children to avoid or request help when using sharp objects. Some AEMT review. The skin has various amounts of thickness. So the two principal areas are your epidermis and dermis. Your epidermis is the tough external layer that forms a watertight cover. The dermis is the inner layer of the skin that lies below the epidermis, and it contains the hair follicles, sweat glands, and sebaceous glands. Blood vessels in the dermis provide skin with nutrients and oxygen. Orifices in the body are lined with mucosous membrane. It also functions to protect the body, sensation, and also regulate temperature. And this is a figure of the layers of the skin as far as the epidermis, and then down into the dermis until you get into the muscle itself. Skin tension wise, skin is arranged to provide tension. Static tension develops over areas that have limited movement. Lacerations occurring parallel to tension lines may remain closed with little or no intervention. Dynamic tension found in areas that lie over muscles. Open injuries to dynamic tension lines interfere with healing because they disrupt the clotting process in the tissue repair cycle itself. So, with closed injuries, soft tissues are often injured when exposed to the environment. You have closed injuries, open injuries, and then burns themselves. Closed injuries are characterized by a history of blunt trauma, pain at the site of injury, swelling beneath the skin, and discoloration. Contusions cause bleeding beneath the skin, but do not break the skin. So you have some pictures of some various contusions here. The one on the bottom of the inner knee there, it looks kind of old. You can see the discoloration. It is turning actually red on the inside, but it's starting to turn black. So this contusion has actually been there for a while. It looks like the contusion on the anterior side of that knee, up above the kneecap itself, is kind of old too. Ecchymosis is black or blue discoloration. Hematoma is a pool of blood collected within damaged tissue or body cavity. Crushing injuries occur when substantial force is applied to the body. And in this picture, just know that your geriatric community and population of patients, they're going to bruise very easily, um, not only due to the fact of the weakening of the skin structure itself, also some medical history this patient may have, which could include some medications that cause this patient to actually bleed a little bit more. All right, crush syndrome. Tissue necrosis develops and results in the release of harmful products in the bloodstream with the limb when the limb is free from entrapment. Renal failure may develop as the kidneys attempt to fill out the harmful products associated with the degradation of dead muscle tissue. Compartment syndrome is characterized by pain that is out of proportion to the injury. So just remember with crush syndrome, especially when you're, and we'll talk about this, I'm sure later, but I always remind you rescue people to let's go through this process slowly. And sometimes if you just reiterate that, they're understand. They're taught that in their classes too. Open injuries, contamination is one big problem. Presence of infectious organisms or foreign bodies. An abrasion causing a part of the body rubs or scrapes across the rough or harsh surfaces. Blood may ooze from the injury, calculated in the dermis. A laceration is a smooth or jagged cut caused by sharp object or a blunt force that tears the tissue. Depth of the injury can vary and may appear lineal or stellate. Avulsions is separation layers of the soft tissue that they become completely detached or hang as a flap. So an amputation is a completely avulsed body part. Consider all animal bites as contaminated and potentially infected. All animal bites. It don't matter if it's an insect up to a dog. Open injuries. A human bite that has penetrated the skin should be regarded as a serious injury also. Penetrating wounds result from a sharp pointed object going through the skin. And that includes your bullets also. An open abdominal wound may expose internal organs. An open neck wound is really potentially life-threatening. Pretty good evisceration. And that looks like an impaled object down there at the bottom. I'm not really sure if that's impaled or he's just having an avulsion of his skin down there. Open crushing injuries may involve damaged internal organs or broken bones. Blast injury may result in multiple penetrating trauma injuries. So, the pathophysiology of wound healing, an infection is increased with size and depth of penetrations. Bacteria account for most bacterial skin infections. Visible clues may be erythema, pus, warmth, edema, and local discomfort. Gangrene, dead tissue itself, causes when blood supply to tissue is interrupted or stopped. Diabetes and atherosclerotic peripheral vascular disease may cause some dead tissue. Also on the medical side, may be caused by traumatic injuries, and it may have a bad color. Late signs discoloration of the limb to black, blue, or red. If not treated, it may become necrotic, resulting in sepsis itself. And a lot of times, these limbs or dead tissue have to be removed or amputated. Tetanus itself is caused by the infection. The body produces a toxin resulting in painful muscle contractions that are strong enough to fracture bones. Rare occurrences become vaccinated. Muscle stiffness may be noted first in the jaw and the neck, and with progression down to the remainder of the body. Necrotic fasciitis is inflammation of the fascia. My serious form of necrotic involves death of tissue from bacterial infections. Look for history. Insect bites, jellyfish stings. Symptoms are reddening of the reddening and warm skin, fever, night sweats, chills, vomiting, and diarrhea. And that's basically where the infection is starting to spread, um, and the body is trying to take care of it. Physicians should always evaluate certain ones. Assessing closed injuries is more difficult than assessing open injuries. Consider substantial underlying injury in case of bruising, swelling, deformity, or pain. So maintain a high index of suspicion for internal injuries and diligently search for ejected patients in the case of a substantial vehicle crash, especially with rollovers. In your primary survey, do not let soft tissue injuries distract you from life threats that may not be readily apparent. Rapidly determine whether the whether threats to life are present using the XABCDE mnemonic. Control your bleeding and perform manual stabilization if you suspect spinal injury. Check for responsiveness, assess the patient's breathing, assess the circulatory status, determine if the patient needs immediate transport or stabilization at this. With your history taken, gather your information, determine mechanism of injury, get your sample, and use OPQRS-T to provide background of isolated extremity injuries. Higher priority should be given to patients taking warfarin and other anticoagulants. And that's what I was talking about with the geriatric patient that we've seen earlier. That looked like almost an avulsion of her skin. And your secondary assessment reveal injuries or other medical conditions missed during the primary survey. Reassess your patient. These injuries can cause shock, so be using your monitoring devices. All your reassessment stuff should be done en route to the hospital. Reassess your ABCs. All bandaging frequently that you perform. Describe the mechanism of injury, position in which you found the patient, and the estimated blood loss. So provide an accurate account of treatment. All right, in emergency medical care of closed and open injuries. Closed injuries, extensive injuries can result in hypervolemic shock and be life-threatening. Can also cause damage to your internal organs. So, treat these patients using mnemonic rest, ice, compression, elevation, and support. Extremities that are painful, swollen, or deformed should be splinted. For signs of shock, place the patient supine. Initiate IV therapy and high flow to and prompt transport. Chemical burns and contamination should be flushed. Apply with dressing and wrap with a bandage. Dressing directly covers the wound and controls bleeding, whereas a bandage keeps the dressing in place. So their primary function is to control bleeding, protect the wound, and prevent contamination and infection. Several types of dressings. Universal dressings, 4x4, 4x8, gauze pads, small adhesive types dressings, soft self-adherent roller dressings, and occlusive dressings. Bandages use soft roller bandages, rolls of gauze, triangle bandages, and adhesive tape. Complications of improperly applied bandages, continued bleeding, additional tissue damage, or even loss of a limb. Always check the limb distal to the bandage for signs of impaired circulation or loss of sensation. All right, management of an avulsion. If possible, place the avulus flap in its original position. Wrap it with separated tissue and sterile gauze and take it to the ED. An amputation, if it involves a large area of the muscle mass, apply a tourniquet and treat the patient for hypervolemic shock. With partial amputations, immobilize the part with bulky compression dressing and a splint to prevent further damage. Bite wounds, prompt control of all bleeding, apply dry sterile dressing, immobilize the area with splint or bandage, and provide transport to the ED for surgical cleansing of the wound and antibiotic therapy. Penetrate wounds, carefully identify all your wounds, address entrance and exit wounds can sometimes be difficult to distinguish. So just count the number of wounds that a patient has and document that. That way you don't get yourself in ballistic concerns if it was to go to legal matters. All right, damage from a gunshot wound is directly related to the size and shape and speed of the bullet. So you see this bottom picture is a small wound, there's possibly an entrance wound. This ladder is possibly an entrance and an exit wound all right there together. So it kind of depends on how a patient puts the weapon up to their skin. Abdominal wounds, if internal organs are protruding through an open wound, do not touch or remove the exposed organs. Cover with a sterile gauze, compressed, moistened with sterile saline, and secure with an occlusive dressing. The patient's legs or knees are uninjured. Flex them to relieve pressure on the abdomen. So, in other words, this is also called an evisceration, which is a medical term when the wounds or correction when the organs are exposed. Make sure you thoroughly cover this with a moist, sterile dressing. It's very possible that you will have to decontaminate these wounds also with sterile saline. So be prepared for that also. Please make sure everything's sterile when you apply these dressings. Impale objects. Stabilize the impale object if you, as much as possible. The object is very long. Cut off the exposed portion first, securing it to minimize motion. Open neck wounds can be life-threatening. Cover with occlusive dressing and apply manual pressure, but do not compress. Burns occur when the body or body part receives more thermal, electrical, or chemical energy or is exposed to more radiation than it can absorb without injury. So it can also be systemic injuries. Also, damaged cells release vasoactive substances, creating an inflammatory response and increasing capillary permeability. Fluid shifting from the intravascular space into the extravascular space causes edema. So, reduced ability to regulate core body temperature. Hypovolemia decreases cardiac output, resulting in hypertension, and a tough leathery substance known as escar is produced. So it can cause circulatory compromise and require an escarotomy. Hypovolemic shock occurs when fluid loss across damaged skin and a series of volume shifts within the rest of the body. Coagulation disorders may cause blood to clot more easily, resulting in emboli or to fail to clot, causing excessive bleeding. All right, there is a high risk of infection, hypothermia, hypovolemia, and shock, so you need to treat these patients aggressively. It may completely narrate obstruction. Circumferential burns of the chest can compromise breathing because of the swelling. Circumferential burns of an extremity can result in compartment syndrome because of the swelling and the closure of the vascular system. Burn zones, skin, ear. The heat source suffers the most profound cellular changes. So it goes through a zone of coagulation, central area of the skin that suffers the most damage. The zone of stasis is peripheral areas surrounding the zone of coagulation. The zone of hyperemia is area last affected by thermal imaging. Burn death, severity of burns is classified according to its death. Differential burns, first degree, involves only the top layer of the skin, which is the epidermis. Okay, so a lot of times, looking at maybe a sunburn. But as most of us know, in North Carolina, these can be very painful. Partial thickness burns is a second degree burns, involves the epidermis and some portions of the dermis, which is your middle picture here. And you actually see some of the fluid buildup from the dermis. Then a full thickness burns extends all through all skin layers and may involve subcutaneous layers, muscle, bone, and internal organs, which is the last picture on the right. So here we have those pictures again. First degree burns only involve the epidermis. Partial thickness is B, and then the full thickness, and it destroys all of them down here to the very right. So 5 factors that affect the severity of a burn is its depth, the extent, and the critical areas involved, such as the face, upper airway, hands, feet, genitalia. Some existing pre-medical conditions and other injuries. Any patient ill under 5-year-olds or older than 55-year-olds, upgrade the burn classification if the answer to the last 3 questions is yes. Rule of 9 is based on dividing the body into 11 sections, each representing approximately 9% of the total body surface area. The rule of palm uses the size of the patient's palm, including the fingers, to represent approximately 1% of the patient's total body surface area. So it's helpful when the burn covers less than 10% of the total body surface areas or is irregularly shaped. So here's the rule of 9. There are a lot of figures out there that a lot of cheat sheets as far as helping you with burns, and what percentage of their body is burn itself. So, but try to memorize as much as possible of this as you can when you go to take your test, because I'm sure there'll be a question about it. So, try to determine whether there are other injuries. Classify the burn to determine its severity. Avoid overlooking the potential life threats that require treatment. Determine the type of burn that's been sustained and mechanism of injury. Assess the scene for any environmental hazards. Determine the number of patients and consider possible spinal injury, inhalation injuries, and other injuries. So, rapid full body scan stridor means the patient's airway is substantially swollen and can signal impeding complete airway obstruction. So be very mindful when you hear stridor. With burn patients also, a lot of times that's inhalation injuries. It may also indicate that this patient is also burned down into the lungs itself. Species of clues that may indicate abuse. As far as in your pediatric population, also your geriatric populations, most people are not going to burn their feet and buttocks circumferentially or around the whole buttocks area up into the hip area. That may be signs of abuse. So you may have to get other people involved also. Check for responsiveness, control life-threatening bleeding, ensure a clear and patent airway. So signs of airway involvement include hoarseness, stridor, cough, sneeze, nasal or facial hair, carbon in their sputum, history of burn or enclosed space. Inspect and palpate the chest wall for decap BTLS. Assess the pulse rate and quality. Provide rapid transport to the closest and most appropriate facility. And if a burn center is not available, a level 1 trauma center is the next best option. A lot of these patients in our area we call for air medical, and most of the time they get transported straight to a burn center. However, air medical is not available. If you can hold these patients until they get to a burn center, if you can properly treat them and route to a burn center, that really helps. All right, investigate the chief complaint or history of present illness. Signs of burns are redness, swelling, blistering, and charring. Symptoms may include pain and or burning at the injury site. Obtain your sample history and ask any necessary questions. Conduct a more detailed physical examination or focused examination of the patient. Quickly assess the patient for decap BTLS. Use the rule of 9 to estimate the burns and determine classification of burns. So look for soot around the mouth or soot, whichever one you say. I say soot around the mouth and nose, thin nasal hairs also. Listen to breath sounds, assess the patient's neurological system, obtain your vital signs, and use monitoring devices. So in your reassessment, repeat primary survey and reassess vital signs. reevaluate interventions and treatment, provide hospital personnel with a description of how the burn occurred, and if special areas are involved, they should be specifically mentioned in documents. All right, the proper emergency medical care for a burn may increase the patient's chance of survival and decrease the risk of duration of long-term disability. Check for traumatic injuries and other medical conditions that may be more immediately life-threatening. The goals are to stop the burning process, assess and treat breathing, support circulation, and provide rapid transport. If signs of hyperperfusion are present, treat aggressively for shock. Aggressive force resuscitation and general wound care may substantially increase the chances of survival. The lengthy transport time, especially over an hour, medical control may order you to administer IV fluids to the burn patient based on the consensus formula. And this formula is a lot of fluid, especially within the first 24 hours. For thermal burns caused by heat, a flame burn is often a deep burn. Hot liquids produce scald injuries. Coming in contact with hot objects produces a contact burn, and a steam burn may produce topical scald burns. Flash burn is produced by an explosion. Inhalation burns, most deaths from fires are caused by inhalation of toxic gases, upper airway compromise, or pulmonary injury. Infection and prevention is vital. It can occur when burning takes place in closed spaces without ventilation. Upper airway damage is often associated with inhalation or superheated gases. Lower airway damage is often associated with the inhalation of chemicals, in particular. Carbon monoxide intoxication may cause permanent damage to organs. So consider whenever a group of people are in the same area or place, and all report a headache or nausea. Be suspicious of pulse ox readings when you are dealing with a patient who is suspected to have carbon monoxide poisoning. Signs and symptoms may include faintness, anxiety, abnormal vital signs, headache, seizures, paralysis, and a coma. Chemical burns can occur whenever a toxic substance contacts the body. Eyes are particularly vulnerable to chemical burn. Wear the appropriate PPE. And in cases of chemical burns or exposure, consider a hazmat team. The severity of chemical burns is related to the pH of the level of the agent used or burnt, concentration of the agent, the length of time the patient was exposed to the agent, the volume, and the physical form of the agent. Treatment can be specific to the chemical agent. So to stop the burning process, remove any chemical away from the patient. Always brush dry chemicals off of the skin and clothing before flushing with the water. After brushing off the chemical, begin to flush the burn area with a large amount of water. More damages may be caused by the chemical reaction of the antidote or neutralizing agent with the contaminant. Specific management techniques: dry lime, flush copiously with a garden hose or shower. Sodium metals cover this type of burn with oil. HF acid, calcium gluconate gel, gasoline or diesel fuel, most hydrocarbons are more effectively removed with such solution. Hot tar, immerse with the affected area with cold. The patient's eye has been burned, hold the eyelid open while flooding the eye with a general stream of water. This, as you can see, could be done one of two ways. This is done with the 10 drop set. You can also use a nasal cannula. Always go from the inside portion of the eye to the outward and then let it drain down the face. All right, electrical burns, contact with high or low voltage electricity occur when the body or part of it completes a circuit connecting a power source to the ground. Can result into burn injuries, entrance wound, and exit wound. Two dangerous areas specifically associated with burns: a large amount of tissue, cardiac or respiratory arrest from electrical shock. So try never attempt to remove someone from an electrical source unless you're specifically trained to do so. So Electrical burns travel the path of connectivity as far as the electrical system of the heart. So be very mindful of the heart damage that can occur with electrical burns, and always monitor your um, rhythms. Be prepared for VFib, VTAC. Radiation burns determine whether as ongoing exposure exists. There's three types: there's alpha, beta, and gamma. Basic exposure pathways: inhalation, ingestion, direct exposure. So a lot of people experience radiation sickness or what radiation. So radiation sickness can cause a premature aging or even death. If not properly trained, maintain a safe distance and wait for hazmat team to decontaminate the patient before initiating care. Establish IV access and give fluid based on the patient's presentation. And that's the end of this chapter. Assess the wound severity. If the wound is in the chest, upper abdomen, or upper back, cover it with an occlusive dressing. Control your bleeding using direct, even pressure dressing, or splint, and then your use of tourniquet.